super excited that you are here. So I'm going to let you introduce yourself and tell everybody a little bit about yourself and go ahead and get started. And
Great.
if anybody's got questions, just put them in the chat and we can answer them either as we're going or we can answer them at the end.
That sounds great. As far as the chat's concerned, I'm not exactly sure how that streams, if it'll show up automatically for me or not. If you're typing something into the chat and I'm not pausing or holding, you know, I don't mind being interrupted. At least we can try that way. You know, however it works, and typically is fine by me. But I'll go ahead and get started. Hopefully everybody can see my screen. I got a PowerPoint with, it's more so for cues and some, you know, visual examples of what things can look like. I have no disclosures. I guess the main indirect conflict of interest that you could consider is that as a Mohs surgeon, I see things through the lenses of a Mohs surgeon. You know, there's a saying: if you go to the barber, you get a haircut, and a little bit of that applies in general when you talk to different medical specialists. They see things in the lenses that they practice with. So when I see a small spot, I'm always worried if it's cancer, because I always see the small spots that turned out to be cancer. The small spots that didn't turn, the 99% that don't turn out to be cancer, I don't even see them. So it gives you an idea of where I'm coming from and how my opinions on things are shaped. A little bit about me. I grew up in Michigan. I went to Johns Hopkins for undergrad. I studied chemical engineering and ended up by working in vaccine manufacturing, at Merck Pharmaceutical Company. Decided that wasn't the career path that I was looking for, so I left and went to medical school at the University of Michigan in Ann Arbor. There's a lot of us out there. You'll find us everywhere. So I did my medical school and master's in clinical research at Michigan, and then stayed in the Department of Dermatology for my residency. From there, I went to Johns Hopkins again for my fellowship in Mohs surgery. And it's a year-long fellowship. I decided to stay on faculty after the completion of my fellowship. And then as faculty there, everything worked out really well, and I got along with everybody well, and ended up by being the unit director and and the clinical co-director of their tumor board. Everything was great there, and then I ended up by having I have a daughter, and then we had twins after that, and it was just too much to manage away from family in the city of Baltimore. So we decided to move up here, and there's a big hole in the map in this area with no one doing Mohs at the time. So it made a lot of sense for us to transition up here. It was about almost 4 years ago now, and it's been great ever since. We helped a lot of people out, all the way from probably Horseheads, Elmira area over to Cooperstown, and then as far north as Cortland. A lot of people who otherwise would be driving a lot farther. Currently practicing, the name of the practice is A New Dermatology. And I would be like the director of the Mohs surgery, skin cancer surgery. And then I have some other folks working with me who help with the medical dermatology, skin checks and things like that. Natalie Roney, Julie Luckman, and Kelly Reynolds. So the goals for the talk, I just want to review some of the skin cancer basics and then transition to a discussion about non-melanoma skin cancer. That's includes most commonly basal cell and squamous cell. There's a lot of other more rare types, but they get grouped as non-melanoma skin cancer, what to look for and the common treatments for those. And then at the end, talk about melanoma a little bit and what that looks like and some of the more common treatments for that. And we can have time for questions at the end if you haven't had a chance to ask. So some of the basics, just generally speaking, it's the most common cancer, skin cancer just in general. There's a lot of new cases every year, and a third of Americans, this is what's amazing. Like, so when I'm in a room and it's me, my nurse, and a patient, it's like, 1 out of 3 people develop a skin cancer over the course of their lives. And, it's amazing. And it makes it so that it's just a common secondary cancer that people get after they've had other types of cancer, just because of its frequency. People are living longer with more leisure time, more outdoors time, and living with other conditions that set them up for skin cancer. So it's becoming a more common diagnosis. Risk factors for skin cancer. These are things that probably aren't going to be terribly surprising. A lot of that is physical features that you may or may not have. And then some are environmental features. My computer is, oh no. That was odd. Environmental factors and exposures. I think I got hit with a pop-up there. So one of those environmental factors that everybody hears about is sun exposure, and just having one blistering sunburn in your youth can increase your risk measurably for skin cancer later in life. So it's something that intervention needs to be focused really on the younger generation, and not that it's not worthwhile doing it now yourselves, but a lot of times you could say a lot of the damage is done from a sun exposure standpoint. The way I like to explain it to people is you think about it at like compounding interest. So when you talk to your high schooler or young college age person, you want them to invest money because a dollar that they invest early on compounds over time. Well, unfortunately, sun exposure does the same thing. So the sun exposure leads to DNA damage, and that as time goes on, those errors in the DNA that lead to cancer compound on themselves. So over time, that 5 minutes of sun when you were 14 and didn't really think about it, you're going to live forever. That adds up and compounds on itself. One of the other big risk factors are existing moles, and some people are just moly people. And a lot of those different, types of moly people, that actually is a risk factor for developing skin cancer later in life. All right, so things that were fairly obvious, light skin, light eyes, light hair, sunburn easily, sun exposure, tanning bed exposure, and then family history of skin cancer and lots of moles, all setups for skin cancer. So the breakdown of the different types of skin cancer, basal cell is by far the most common, and much less than that is squamous cell and melanoma. Fortunately, basal cell is probably, generally speaking, considered less aggressive than the others, and that's not to say that a neglected basal cell can't give you a lot of trouble. Both from a removal standpoint, it can be life-threatening if you don't treat it appropriately. So those are the three kind of main and most common types of skin cancer: basal cell, squamous cell, and melanoma. The basal cell and the squamous cell are grouped together as the non-melanoma skin cancers, and then the melanoma is kind of more of its own animal. Even though it's the least common of the three, it's quite significant because of its ability to rapidly spread throughout the body, shorten people's lives. So this is a cross section here of the skin, and it gives you a brief schematic about some of the outer layers of the skin and where some of these cells come from. So squamous cells, are more of a kind of differentiated version of a basal cell. Basal cells, by and large, they live at the bottom of the outer layer of the skin. So between the first layer, basically, and the second layer. The squamous cells are all the cells kind of above that in the outer layer. And then melanocytes, they're also usually living at the junction between the outer layer and the middle layer, but they're a totally different, unrelated cell type. So like I was hinting at, there's a lot of diagnoses of these non-melanoma skin cancers, relatively compared to probably a lot of the cancers that you guys encounter and hear about and talk about, relatively low death rate from it, fortunately. And a lot of those are going to be due to the squamous cells, and then particularly in patients who've had transplants who are otherwise immune suppressed, or other factors that set them up for getting these. Generally, they're easily treated compared to others. So this is I'm going to go through a couple of examples of basal cell skin cancer, because this is, I think, something that's really helpful. You know, over time, people just accumulate spots. You grow new spots, and if you got, you know, worried and freaked out and went to the doctor on every single spot you grew, you'd probably spend all day, every day going to a dermatologist. It's just kind of one of the facts of life. Spots accumulate over time. So it's helpful to have a little bit of an idea of what to look for. Now, the examples I'm giving are not the end all be all. And if you're not sure something's not acting right, always go get it checked out for sure. But you know, this is like if you had to put a picture in a textbook of a basal cell, this is about it. It's shiny. You can see those extra blood vessels there, and you know, it's a very classic spot. What people come in and who've never had one of these before, they always come in and they say, "Hey doc, you know, I thought this was just a little pimple. It just wasn't going away." And that's the story that I hear all day long. So if you've got a pimple on your nose or on your cheek or something like that, and it's just not going away, you know, it may not be a pimple. Oh, there we go. Okay. And this is a little bit of a crustier version of the one in the preceding example. They can be a little bit more red in the background. Very common appearance to them, very common location. The nose is the most common location to get one of these, unfortunately. It's just, you know, kind of like that shiny skin colored bump with the extra blood vessels there. And sometimes they're less of a bump and they're more almost like an indentation or a scar. And that's what you can see on this spot here. It's more of an indentation in the tip of this gentleman's nose. And then sometimes they grow out more. This is probably less common that they do this, but they sure can. And this is another one of those scar-like and infiltrative types. You know, this is something that wouldn't heal. And, you know, when shaving, it would start to bleed. These are particularly tough ones behind the ear. I see a lot of spots like this behind the ear because they're not an easy spot to look and find out what's going on back there. You know, you can't really see it easily yourself. And you know, if you feel it with your fingers, it feels like kind of just dry skin. So you're not terribly worried about it and it doesn't change very much. So if you got something that's just not healing, you know, even behind the ear, you got to get it checked out. And then this is more of an obvious one, you know, near the eye. You can get these basically on any part of the skin, anywhere. And I've seen these, you know, even though they're very heavily related to sun exposure over your life, I've seen these in people of all varying skin types, you know, very, very dark skin types to, you know, the very fair skin types too. So changing gears a little bit, these are squamous cell skin cancers. Some features can be a little bit similar, but there's some overarching, you know, differences, and they're often more crusty, scaly. And people, you know, when patients come in with you know, one of these for the first time, they'll often say, "Hey doc, you know, I just had this scaly spot there, didn't think anything of it, and then all of a sudden it seemed like it was erupting, almost like a volcano." And it gets kind of crusty and hard in the center, almost like there's a core to it, and it can grow pretty quickly. That's one of the bigger differences between squamous and basal cells. Squamous cells can grow relatively quickly versus basal cells. So that's a kind of a classic appearance of one. You can imagine, you know, this looking like a volcano erupting. And then this is a little bit more of a subtle one on the rim of the ear. And this reminds me that one of the differentiating factors. So when I see patients and, you know, they have maybe 30 little flat scaly spots like this that you know, it's hard to differentiate much between them. One of the things that can push me more in the direction of biopsying something, because I'm not sure if it might be squamous cell skin cancer, is if it's painful. You know, it's not 100% predictive of something turning over into a squamous cell, but it's something that is helpful in identifying one that may be more likely a squamous cell versus some of the others that are probably just precancers, and you may not need a biopsy and can just be frozen with liquid nitrogen. And yet another example, you know, similar to some of the ones we were just seeing. And then this is another one that is very interesting. You know, you look at this and squamous cell isn't necessarily the first thing that pops into my mind. You know, it's funny looking. It's obviously something I'd want to biopsy, but it could be, you know, a melanoma. It could be a pre-melanoma. It could be like eczema with like a mole in the middle of it. But it turned out to be squamous cell, and so you can have discolored squamous cells, in the red spectrum, and then sometimes you can get hyperpigmented, so they're more in the brown, brownish spectrum. Good. And just like squamous cells can grow more rapidly, they're also more likely to spread inside the body than basal cells. So the place that they tend to spread first are lymph nodes, and I'm sure you guys kind of hear about those related to other conditions. One major set in the head and neck is in the parotid, which is by this arrow that's kind of on the front part there by the cheek, almost where if you clenched your jaws, right about where you feel that muscle, flex. That's right about where you're talking. And then back in the deeper chain down in the neck, it would be another place that it would subsequently spread to. So just that's just like a 10,000 foot view of basal cell and squamous cell, what they look like, and kind of just a little bit about their background. Transitioning into treatments, by and large, the treatment for these is fairly similar. Now, there's some differences when it comes to things that are more aggressive or outside the beaten path as far as how large they are and what structures are nearby. But basically, basal cells and squamous cells are treated fairly similarly, which is why they end up by getting grouped together. So there's three main standard types of treatments for them. Electrodesiccation curettage is the first one. Excision, a traditional excision, would be the second standard therapy, and then radiation therapy would be considered the third standard therapy. And the majority of these skin cancers, basal cell and squamous cell, would be considered low risk and appropriately treated with one of these types of standard therapy. The first one, ED&C, electrodesiccation and curettage. It's a mouthful. The lay term for it would be a scrape and burn. It sounds pleasant. It's actually not. It's not as bad as it sounds. The skin gets numbed up, very similar to the way a biopsy would be done, and an electric needle is used to essentially to dry out and burn the skin cancer cells on the outer layers of skin. Because it's something that it inherently doesn't go quite as deep as some of the other treatment options. It's something that tends to be used only for more superficial types of skin cancer. So, when a biopsy is done of a suspicious looking spot, it goes off to the lab, and the lab looks at it and says, yeah, it's cancer, or no, it's not. But if it's cancer, then they give some additional description to it as to like where it's located. Is it superficial? Is it very infiltrative, or is it very deep? And things that are more superficial are more amenable to treatment with this electrodesiccation and curettage, ED&C. So with a in situ squamous cell, which would be a very superficial, non-invasive squamous cell, you can get a cure rate about 90% with a scrape and burn type of a procedure. And then similarly with superficial basal cell, or sometimes nodular basal cells even, the cure rate with this goes way down quickly if you're talking about a deeper type of a tumor, or if you're talking about a location that's considered higher risk, say around the eye, or the ear, lips, nose. So it's really mostly used for the superficial, less aggressive cancers that are in low risk locations in the body, like the arms, legs, trunk, those types of areas. The benefit to, there's an example of kind of what it looks like. The benefit of doing it is, the summary would be kind of like low tech but effective. It's basically something that it doesn't go terribly deep inherently, so it allows for relatively faster healing time, especially when you're talking about areas that are like on the shins or the legs, areas that don't heal terribly well to begin with. So that's when I would typically use something like this. The disadvantages Sometimes, sometimes it can take, a longer time for them to heal. Sometimes, the cosmetic outcome, it's debatable, whether it's acceptable or not. It's more of like a kind of a circular type of a scar rather than a line scar. And it's done by feel rather than by getting like a clear pathology report on the margins. So it's something that's operator dependent, and it very much depends on the type and location of the tumor you're treating. The second standard of therapy would be excision. So this would be a very common, type of a spot that would be very amenable to a standard excision. You can see the lesion is there circled in the center with a solid circle, and then around that there's this dashed circle. And that's about, a 5 millimeter safety margin of normal looking skin all the way around. So that's what you're looking at for a standard excision. And then these triangles get drawn on either end. And those triangles have to do with how it would get stitched together. And I always like to explain it like, if you imagine having, if I just cut out the bare minimum, just the circle with the safety margin, and we tried to stitch that together. You put a stitch on one side, you put a stitch on the other side of the circle, and you drew it together. The opposite ends, they would pleat and they would double up, kind of like pleats on a pant. So you got to take those darts out to allow the skin to lay flat. So it starts out as the cancer in the middle plus the safety margin. Then you got to tack on for the length of the scar in the end, you got to tack on that additional dart of tissue just to account for the stitching. Here's another good example. And this is probably the biggest difference between, one of the most important differences I would say between Mohs surgery and traditional excision for the removal of skin cancer. With traditional surgery or traditional excision, the sample gets removed from, one of those drawings, the football shaped drawing gets removed, and then it goes to the lab and they process it with something called bread loaf sectioning. And if you could imagine a loaf of bread being cut, this is very similar to what they're talking about for this. So just like, you got a loaf of bread and it gets cut up and down, just like this sample would get cut up and down that gets removed. And this is with traditional excision. The sections that get cut, they get placed flat, essentially on the slide. So you only really see the faces of each cut. You don't see what's in the crust when traditional excision is being evaluated under the microscope. In all, 5-ish plus minus % of the total peripheral area of the sample gets evaluated using a traditional excision. Then the rest of the 95%, an inference is made based on what the pathologist is seeing in those, on the faces of the slices of bread. It's a little bit of a, it's something that you got to kind of like think through. Is that making sense to everybody? The analogy, the bread loaf analogy, and then, kind of seeing only what's on the face of the slices of bread, because it's kind of an important concept. Does anybody, have any questions related to that? We're good. Okay. Excellent. So this is an example showing again that, the bread loaf sectioning and how it's definitely possible for, for when they take their bread loaf pieces, for them to look at the front of it and for it to look clear at the margins based on what they look at, but yet have the tumor extend, to the periphery of the sample. So that's really where Mohs comes in. I'm not going to talk about Mohs quite yet. We have one last thing to talk about before we get there. Advantages, you get some margin control. There's somewhere between, like I said, 1% and 5%, kind of depending on how the pathologist does it, of how much the margin gets evaluated with these traditional excisions, is kind of the drawback. And then lastly, radiation therapy. This is the last of the therapies that are considered standard or usual. So with radiation therapy, the specifics are best kind of discussed with somebody who does this radiation more frequently, but generally speaking for skin, You go, they plan out their procedure, and then you go for treatments that last, for a couple of minutes, but you do it 4 to 5 times per week for 4 to 6 weeks. And now there's different, protocols based on the tumor type and location. But generally speaking, it's something that, it's a series of treatments over a longer period of time. It's generally well tolerated, and it can, for someone who may not tolerate surgery, they have a lot of complicating medical conditions, or the tumor is, stuck to something bad where, where they, you're not gonna be able to get clear margins. It's something that's generally well tolerated. Some of the drawbacks are it takes a lot of treatment, so you got to keep going back to get it treated. The skin has some breakdown, and then and you don't get margin control, meaning you don't get anybody, there's no look at the margins to see if it's gone or not. You find out whether the cancer is clear and treated, basically, is if it doesn't come back. There's no like necessarily like rebiopsy or anything like that happens. So like I was saying, the majority of basal cells and squamous cells are treated with a standard type therapy. But there's certain higher risk basal cells or squamous cells based on the pathology, features or patient factors or location that make them, more appropriate for treatment with maybe a non-standard therapy such as Mohs. So with the low risk lesions that we've been talking about, the ones that are appropriate, standard therapy, you can get a very good cure rate, with those standard therapies, particularly excision. But some of the higher risk lesions in higher risk locations, those cure rates drop quite significantly. Things that make a tumor higher risk, like I've been mentioning, the location of the tumor. If you take the same basal cell, the nodular basal cell, if you put it on your eyelid or put it on your nose, it would be high risk. But if you take that same spot and same exact size and everything, you put it on your forearm, it would be considered low risk of coming back after surgery. Or tumor characteristics, meaning like what's the growth pattern like of the skin cancer? Does it go very deep? Does it have a lot of roots? That type of thing. Size can contribute to it. And then some other factors like patient factors, like people who are immune suppressed, or if the cancer is recurrent, meaning it's already been worked on once and now it's come back. Those all make it higher risk. So this one, location on this makes it higher risk. And then when I was talking about some of the pathology features of the tumor, I think seeing this is a great example because it lets you see, when I go in to talk about the growth pattern or what it looked like under the microscope, this would be what would be considered a nodular basal cell. And you look at it, it looks like a nodule, it looks like a potato kind of underneath the skin. And you can imagine that, if you were trying to cut that out, it's relatively easy to pinpoint where the edges of it are, and you can cut it out successfully with a little safety margin to it. Very different from this, where this would be a more infiltrative or aggressive growth pattern, and this is really more like those mangrove tree roots in the swamp. They're really twisty, windy, and they're very thin versus the surrounding normal tissue, and they go right into the normal surrounding tissue. So when you look at this from the top of the skin, it doesn't look like much. It looks almost like normal skin there. So when you go to remove this with a traditional type of a treatment, it's much easier to miss what the edge would really be. Because you're basing your initial treatment off of where you see the abnormality. So when you see this on pathology, this is something that often kind of clues people into needing something like Mohs that's a more aggressive type therapy. So this is a great visual example of when I'm talking about something that location on this and then the size of this would make it very, very appropriate to treat with a more aggressive therapy. It's almost going to be the entire upper part of the ear involved in this. And then slightly differently, this spot here, the challenge is a little bit different on this gentleman's forehead. You look at this and you're like, oh, where does it even start? We're talking about this thing in the middle. It's hard to say even where it starts and stops. So yes, you can see the abnormality there in the middle, but is the edge of it here? It's really hard to say. So just a summary of the high risk features. So high risk features, make something, they would make something appropriate to treat with Mohs. And I say it like that because not necessarily every high risk skin cancer ends up by being treated with Mohs. They get treated, all the time successfully with a traditional excision or something like that. And if you have it available and it makes sense, then fine. There are a whole bunch of factors that can guide us in a different direction in our decision making, whether something is, even though it's high risk based on location, size, growth pattern, etc., Mohs or not. And sometimes people they're not going to tolerate having surgery under local anesthesia. It's not something that everybody can do. So if that's the case, then we send them for a traditional excision in the operating room, and that's fine. And they just take a little bit extra tissue kind of just take care of it that way. So changing gears here to talk more specifically about this Mohs surgery that I do. It's named after a gentleman, Frederick Mohs from Wisconsin. He came up with it, like a lot of great things in medicine, figured it out when he was like a medical student early in his career. It was a very logical approach to treating things. He wanted to get to remove skin cancers in a way that he was able to look at the entire margin. The procedure he used back then is a little bit different than what we're currently doing, but the fundamentals and the principles remain the same. And the zinc chloride paste stuff, we don't use this stuff anymore. That's what I was talking about. It's done differently now, but the bottom line is, it was developed quite some time ago. It's just being more popularized lately because the increased incidence of these skin cancers. Example of a tumor here being removed, and this is how it's removed with the Mohs surgery. It's removed almost like a golf divot, you can imagine. And then the cancer gets separated and it gets mapped. So each piece gets oriented so that you can ink it, and then it gets processed. And the person who looks at the slides, the surgeon who looks at the slides, is able to figure out what's north, south, east, and west. And for a tumor like this, you'd have the first stage and it would be found positive, to the deep here, and there would be a second stage, maybe a third stage to get it all out. And here's a busy schematic of kind of talking about the same thing. So with these high-risk skin cancers, 5-year cure rates with Mohs are very good, very, very good. When you're talking about basal cells that have not been operated on before, so they're the first time they've had surgery, you're getting in the 99% cure rate with Mohs surgery. Once if you're talking more about, squamous cells that are very large in patients, who have immune suppression, you're talking more than, 90 to 94% ballpark for cure. But, Mohs surgery, you can see how there's a benefit over the high risk, or over the standard therapies for high risk type skin cancers. It's probably a good point, to stop to see if anybody has any questions. Covered a lot of ground pretty quickly. Yep, we got one right there. Go ahead.
Dr. Egbers, are you familiar with a study out of Stanford in 2018 about the number of basal cells people might have that influence whether their DNA is able to repair itself, and even as few as 6 basal cells can lead to an increase in other kinds of cancers?
Yeah, I am familiar with it, it does make sense, and I think that we haven't really fully figured out how to implement that. However, if I do see somebody with a lot of skin cancers, I do definitely ask about family history and things like that. And if somebody does have indications that they're kind of like high risk for internal malignancies, that's somebody who I would send on to like a medical geneticist, elsewhere. I feel like it's still in a very kind of a developing area um, of skin cancer treatment and management, and there's really not great crystal clear guidelines on exactly how to implement it. I think you're going to probably find a wide range of kind of what people do about that. But I have definitely heard of the study, and it's a logical, logical endpoint. It's a good question. Any
Well,
other questions?
my
Oh, okay.
husband, my late husband had a significant number of basal cells. He grew up and lived for the first 30 years of his life in Colorado, and ended up probably having, I want to say, over 20 basal cells and one squamous cell, and then 4 other cancers that he had between 1999 and when he died last year. So,
Sorry to hear that.
thank you. So I just kind of spread the word to people who have a lot of basal cells to make sure that if they ever have one slight little thing that they think could be a problem, that they go and see their doctor.
Definitely. Yeah. You got to be your kind of own best advocate on that sometimes. And I think that's definitely a good word to spread. And I think that it kind of like holds for really anytime there's an outlier situation, whether it's squamous, basal, or otherwise, it's kind of an indication of potentially a bigger issue. Good. Any other questions?
Yes, Ellie?
Just a comment. I'm a retired nurse practitioner, but I had a squamous cell in my 70s, early 70s, and it presented like a sore that wouldn't heal. It looked like a pimple. When I'd scratch it, it would slightly bleed, and it just never went away. So I finally decided to go get it checked out, and to my surprise, surprise. And unfortunately, the Mohs surgeon that was with Guthrie system moved out of the Corning area. So I'm glad to see you're in Johnson City, should I ever have any further problems. I was somebody, I didn't go to the beach often, but in my 40s, did sun tanning salons. And I'm sure that was the, predisposing factor.
Well, it didn't help, that's for sure.
And, ever since then, I use a 70 SPF sunscreen every day, rain or shine, cloudy or sunny. Yeah.
No, I mean, I want to I want to highlight something that you said, and typically I hear it, very often for basal cells, but I mean, it holds true for sure for squamous cells too. Like if you're in the back of your mind sitting there thinking this pimple isn't healing, like if you could have one sentence takeaway, one phrase takeaway, I feel like that's maybe one of the best indicators. I just like, it's almost, I should record patients saying that, and I could have thousands and thousands of people saying that. It's just the most common kind of underlying thread. Just, doc, I thought it was just like a pimple that wouldn't heal. So like if anybody ever has anything like that, you definitely want to get it checked out.
Thank you.
Yeah, absolutely.
Are there any other questions? Yes, Sharon.
I would just like to make a plug for regular screenings, because I didn't notice anything odd about a spot on my nose until I went to my dermatologist in Ithaca, and she was suspicious of it, sent me to Dr. Egbers, who did Mohs surgery. And I just had no clue that anything was going on. So regular screenings are just so essential. Don't wait until you see something.
Thank you for that. And I need to put that higher up in my talk, probably near the beginning, really, because you're right. I mean, the time we want to find these is before they're at the point of a pimple not healing, right? I mean, when you can find it before then, that's all the better for sure. So yeah, I totally agree.
Hey, anybody else? Okay, I think we're good.
All right, great. So changing gears. Oh, and one last thing I wanted to say about that, there are actually Ithaca, I don't think Ithaca has anybody doing Mohs right now, but they do have a number of very good dermatologists and dermatology groups. So you should be able to get in somewhere. Dr. Garner's great. The Dermatology Associates of Ithaca, fantastic. And then the Cayuga group. I mean, probably have more dermatologists per capita in Ithaca probably than anywhere else in Central New York. So you guys should be able to. It's one thing you should be able to access nicely there. So don't hesitate. All right, so melanoma, it's derived from a totally different cell lineage. It's very unrelated to basal cell and squamous cell. It's the breakdown of melanoma. It's the least common, fortunately, because it can be the most aggressive. And of the types of melanoma out there, the looking at the 115,000, the old numbers, but the percentages are relatively true still. The breakdown is just under 50-50 on the in situ versus invasive, and that's a huge differentiating factor there, catching these while they're still in situ. With in situ surgery, surgery alone is really kind of curative, versus when they start to become invasive, very quickly they can get out and start causing you distant trouble other parts of the body. The majority of skin cancer deaths in the country are related to melanoma versus the other types of skin cancer. It's actually the #1 type of cancer in young adults. Very common overall in Americans, 1 out of 50 Americans, and that's an incidence that's climbing. Overall mortality is relatively low, but this is totally dependent. It's hard to even put that up there because it's so dependent upon what stage and how advanced the melanoma is diagnosed. If caught early, though, it's very curable. Like I said, in those in situ types of melanoma. And a lot of the same risk factors that set you up for non-melanoma skin cancer are setups for melanoma skin cancer. This is just a kind of a graph showing, the lifetime risk of developing a melanoma based on, the year that you were born. It's becoming more of a problem over time, and it's thought that there's a lot of things that could be contributing to this, like people living longer, more leisure time, more sun exposure, potentially biases in diagnosis. So like are things that we 20 years ago wouldn't call melanoma, we're calling melanoma as we find out more about how they act over time, those type of factors. And they can look very differently. They're like a irregular looking mole, discolored patch of skin. You really want to catch it, but long before it's something like this, obviously. And they can have more pimply red areas. I've seen melanoma look almost like anything. It can look like sometimes can look like a large squamous cell or a basal cell. Which is why we really need to take, even though something looks like a basal cell to the eye, you still have to send that biopsy off before you start doing any types of surgery, because you really do want to have the right type of surgery for the type of cancer that you're trying to treat. So these, if you look online, you'll see all sorts of different things that can help you key into whether a spot is melanoma or pre-melanoma or something like that. And they come up with the ABCDs, the asymmetry, border, color, and diameter. I always throw an E on there, and it may be on one of the next slides coming up here. E is for evolution. It's often one of the more important factors. So like, even if you came in to see me and the spot was really not that bad looking, if somebody's telling me that it's changing, it's changing in a certain way, and it's growing or becoming a different color, becoming inflamed, something like that, that's often enough just to take a biopsy on that. But these other factors are factors that are associated with something being a melanoma. These are designed to be broad and capture more people with benign lesions, trying to not miss anybody who actually, has a melanoma. So meaning if you look at your skin and you try to apply these criteria in an absolute fashion, you may be able to come up with many spots that may qualify. That doesn't necessarily mean that you have many melanomas. It means that you have many lesions that need to be checked. And, you know, it's a checked can mean many things. It can mean biopsied. It can mean just, you know, inspected visually with your dermatologist. There's currently no, you know, scan that you can kind of just run people through to scan, you know, their skin for the development of these or the existence of these. I was working with a group that was trying to put one together, maybe, I don't know, 6 years ago, 7 years ago, something like that. The logistics of it are challenging, and my guess is eventually, sooner than later, it will be a thing. It's just not quite there yet. The improvement in artificial intelligence since then, I think, is going to be a big driver in being able to come up with something to assist in the detection of these early. I know Google has an AI-based application that can be used to help identify something like this. It's not clinically approved or you know, FDA approved, but it's something that you know, does exist. And I think that the direction of detection of these in part is going to be assisted at some point by imaging and artificial intelligence. You know, there's in addition to the evolution feature, there's this additional feature, this ugly duckling. So like, if all of your moles are regularly irregular, it's a little bit less concerning than if one of them is a standout. And if all of your moles are light to medium brown and look like one another, or you know, you've got a couple of different families, it's generally reassuring. But if you have one that's twice as big as the others, or one that's you know, jet black and all the other ones are light brown, that's a concerning feature. So in addition to the basic ABCDs, the E for evolution and then the ugly duckling, I think are important add-ons to that. And this is something that I'm sure, if, you know, there's got to be at least somebody out there who's got spots like this on their back. They're these, you know, kind of age-related wisdom. I call them wisdom spots rather than age spots, but they're wisdom-related growths that are benign, and they're very common on the back, and they arrange themselves like this, kind of almost like a Christmas tree pattern away from the center. And the challenge becomes identifying a melanoma amongst all these benign, appearing lesions, because color-wise they match. But out of all of these, there's one melanoma there, and that's this spot. So that's why, you know, those ABCDs are designed the way they are, that, you know, you got to go in, and if you had spots like this on your back, you know, there's probably 30 spots there that would justify, you know, asking about, but there's one that's going to be problematic. So, you know, don't feel like you need to be exactly right on every spot you go in and ask about. It's better to ask about, I tell people it's better to ask about 30 spots and not miss a melanoma than to stay at home and not ask about a spot that you're concerned about or wondering about, you know, that may have a feature for melanoma. And it can happen anywhere, you know, on the scalp. I found them, and on the ears, inside the bowl of the ear, on the conjunctiva of the eye. It's a really tough one. On the inside of the lips, bottom of the feet. A little trivia, you know, my understanding of what led to Bob Marley passing was actually acral melanoma. So melanoma of the foot, believe it or not. And it can happen to people of any skin type. All right, so more about melanoma and what dictates whether something is, you know, going to be aggressive or not aggressive. The biggest first predictor of how aggressive this melanoma is going to be, or how advanced it is how deep it is. So when a biopsy is taken, the pathologist looks at it and they say, okay, all right, it's got features of melanoma, Then the next thing that they look for is how deep does it go? So they measure from one of the outer layers of skin down to the deepest melanoma cells that they can find. And they actually measure it, and they assign something, it's called the Breslow depth. And that's the best kind of prognostic indicator for how that melanoma is going to act initially, and dictates the next step treatments for that spot. So this is kind of just a schematic of kind of how melanoma progresses, starting in the outer layer, and then it starts to invade down into the skin. And there's the old first kind of demarcation was at 1 millimeter, and more recently, based on research, the cutoff has been shortened down to 0.75. So that first cutoff is really what determines whether someone needs to go for additional testing of lymph nodes, sentinel lymph node biopsy, and additional treatment in addition to just traditional surgery. So if you're melanoma in situ or stage 1A, the typical standard treatment is an excisional surgery. So, the Breslow depth, like I said, is the first initial indicator of how it's going to be. If the Breslow depth of the lesion indicates that, more testing needs to be done of the lymph nodes, then the lymph nodes become an important prognostic indicator for whether this is going to spread systemically or be found elsewhere in the body. There's these other two factors that ulceration and mitotic rate that the pathologist will report on. And the ulceration is something that you'll typically find on a more advanced melanoma. Mitotic rate's interesting because it's something that you can have, it's an indication of how fast the cells are dividing and growing, basically. And you can imagine a scenario where if a pathologist is looking at the cancer under the microscope and it's got a lot of mitoses, a lot of these mitotic figures, basically it's capturing the cell in the process of dividing. It would make sense that it would be more aggressive, and it does turn out to contribute to how aggressive the melanoma can be. All right, so like I was talking about, excision is the standard for thinner melanomas, and then anything that's stage 1B or greater typically gets sent for sentinel lymph node excision plus sentinel lymph node biopsy, and surgery is really the mainstay for melanoma therapy. There are maybe have half of us comment on one slide down the road, so don't mind. Melanoma is a very interesting area right now where there's just like other cancers where the immunotherapy treatments are being found to be very effective in some people in producing a long-term period of no evidence of disease where they previously had significant tumor burden, systemically. So as developments continue to occur with immunotherapy, melanoma that previously would have been considered untreatable, and there are treatments available now that there really weren't 5 or 10 years ago. So it's a good area of research, fortunately for people. So excision with melanoma. Melanoma is typically treated with excisional surgery, a more traditional excision. And the margins are dictated based off of large, case series and research studies. And they're wider than those for non-melanoma skin cancer because of melanoma's general aggressiveness. It's better to be more aggressive in your removal of your melanoma and get clear margins than to sacrifice cure rate potentially for tissue sparing and leaving normal tissue. So for a melanoma in situ, that's like the least invasive, they're non-invasive basically melanoma. The margins, recommended margins are between 0.5 centimeters, half a centimeter, and a whole centimeter just for that, which is already, that's far larger than what you'd be doing for basal cell or squamous cell. And, you know, the recommended margins go up from there based on the depth. But the excision of the site where the primary melanoma is really designed to capture the melanoma just in the spot where it is. It doesn't do anything about the melanoma if it's started to go elsewhere in the body. So this is just a kind of a prompt of the dandelions that turn into those little puff balls things with the seeds that you blow and they can, you know, they kind of fly off. You know, melanoma is one of those skin cancers that can spread relatively quickly. And just like those little seeds kind of fly off elsewhere, that the melanoma can do the same. And the first place that it typically will go is to the sentinel lymph node. It's the first lymph node in the chain upstream from where the cancer is. Now there's all sorts of variations to that, but it's generally speaking, that's the case. For that type of a procedure, it's something that you're talking general anesthesia for, and for those people with a higher risk for sentinel lymph node involvement. All right, good. So this is where I was talking about the systemic immunotherapies. You know, not much else to add to that. Just basically be smart about being out in the sun. These are some kind of like parting thoughts that I probably didn't highlight earlier on that are worth commenting on. Because once you've been diagnosed with a skin cancer, people, it can be quite overwhelming, and people are like, "Doc, do I need to stay inside all the time, or you can't go out in the sun anymore?" I feel like you got to use a degree of common sense with it, and you know, you want to use sun protective clothing when you can, including hats and, you know, the long sleeve shirts, sunglasses, sunscreen, and avoid being out in the sun during the peak hours. You know, between 12 and 4, something like that, or 10 and 4, something like that. And if you have to be, definitely wear sunscreen, even if you are wearing a hat, and definitely avoid tanning beds. The ABCDEs, we talked about those, and then ask your body. So this is super important too. So like, you know, you may go to a dermatologist or to your general doctor and you ask them about a spot. If you're asking about a spot and you haven't had a total body skin check in a while, a year or more, you should really just ask for a skin check. They may not be probably not able to do it like right then and there, but if you're worried about a spot, you should be, you know, worried about the rest of your skin too. It's so common where a patient comes in, they're asking about a spot, you know, on the back or on the temple, and turns out they got a spot, you know, on their scalp or, you know, behind their ear that they didn't even know was there. So it's a good opportunity to get everything checked out. And then these are my little guys. They were dressed up as Wendy, Tinkerbell, and Peter Pan. And it's one of those like classic, you know, you bring the photographer in situations where, you know, at least one of them was fussing the entire time. And this is about the best picture we got out of the whole thing. So it was Halloween, you know, maybe 3 years ago, I think. But happy to answer any questions that may have come up. I know we covered a lot of ground on these things.
I was going to say, if you don't have anything that you think is abnormal, how often would you recommend a full body skin check?
That's a great question. And I think it's good to go in and have a baseline if you haven't had one in a while. Say you got no spots you're worried about. If it's been and what do I mean by a while? If it's been a year or more, really, and you haven't gone into the dermatologist for a skin check, you should go. And part of your discussion with them should be based on what they're seeing, what should your frequency be going forward? Because, you know, just because I might not find something, it doesn't mean. I have patients that I see sometimes with certain conditions where, you know, I might need to see them every 3 months. I might not have biopsied anything 3 months ago, or even this time when I see them, but I still need to see them back 3 months from then. There are also patients that I see where their skin is just pristine, and they just don't have anything they don't have anything close to anything. And I say, 18 months, 2 years, a year to 2 years, whatever, you know, kind of wherever they're comfortable with. I'm very wishy-washy about things on that end of the spectrum because there's not very good guidance.
Okay.
The current research is not very effective in helping us pin down what the optimal frequency of skin checks are. It's something that I think, like, there's still a question mark as to, the benefit for it in the minds of insurers and, and some other people too. So it's a lot of it is going to be, though, based off of what your dermatologist is finding on your skin, when you see them. So whenever you go see them, you should ask what, well, based on what I got, what frequency should I be at?
Okay.
Yeah.
Yes, Colleen.
That's a good question. Yeah.
Thank you.
Yeah.
Yes, I think I unmuted myself. In tying in with that about how frequently you should
Mhm.
see a dermatologist, I just wanted to comment that
Mm.
the pictures you showed of melanoma didn't look like mine.
Mm.
I didn't really have a spot. It was just discolored a bit.
Mhm.
And the way it was caught was my cousin is a PA in Rochester. One of her best friends is a dermatologist. We're at Thanksgiving and she said, go have that spot checked out. And when I went to the doctor, living in Ithaca at the time, this is 9 years ago, the nearest dermatologist I could see was in over by Elmira.
Mhm.
And that doctor looked at it and said, don't worry about it. I don't think it's cancer. And at the second meeting, she said, well, don't worry about it. I don't think it's melanoma.
Mm.
And then after she took it out, she said, well, don't Google it, but it is melanoma.
Oh boy.
And the edges aren't clear.
Yeah.
And at that point, I went back to New Jersey, saw my primary, who just looked at me and said, you need a Mohs surgeon.
Yeah.
And I did not want to do it in New Jersey. So again, my cousin's best friend is associated with a Mohs surgeon in Rochester. So in my case, I was just lucky all around, but it was not anything I would go to a dermatologist for. So now I'm like really big on, you got to go to the dermatologist at least once. I go once a year, but because I had this, but I think even more often. Well, I think if you haven't had this, I wish there was a guideline that said everybody goes and gets checked at this age and then so many years.
I agree with you.
afterwards.
I very much echo what you're saying, and I really wish there was better guidance on the skin check, frequency, and to kind of encourage people to get them younger too, because I feel like it's what happens a lot are there's a delay, especially in the first skin check. People are apprehensive, and or they're busy and they there's other pressing issues. Getting in for an initial skin check, I think, is really important to get a baseline.
And at what age do you think that should happen?
I don't think there should be a lower age on it. I don't want to, if you haven't had a skin check of any type and you have, no spots of any concern, that's where things get really gray. I would say maybe start with your primary care doctor as part of your yearly physical, if you're say in your 30s or 40 or something. But the thing is, I see patients, I was just doing surgery on a patient who's like 35 and, on her nose, and there's really no lower age on it. And I think it's helpful to have a baseline, have someone at least give you a good look over, and then they can be like, okay, based on what I'm seeing, you could probably go for a little while. There's really not much anything going on right now. And then a lot of times I give people homework and I say, all right, look, everything's looking okay now, but if I had to pick 3 spots that I was the most worried about, I would say it was because things may look okay today. But the reality is it's one slice in time. And that evolution piece, I think, is such a big part of it, that seeing you once and then seeing you a year from then or whatever, it really can't, it's hard to account for, or even 18 months or 2 years, whatever, it's hard to account for that evolution piece, but it's something that you're able to do especially if it's in a location that you can keep an eye on. And then I tell you, like, look, if it's changing, come back, and we'll do some sampling on it, because things do change. There was one point in your life where you had like essentially no spots or almost no spots, and obviously things change, right? So you got to kind of be aware of that evolution piece. So
Yep.
I think we have another question. Yep.
So wouldn't a good thing be to ask your primary care physician or discuss your skin? Like I have 6, if not 7 of the risk factors for melanoma.
Mhm.
Red hair, blue eyes,
Mhm.
major sunburns as a kid. There
Mhm.
wasn't sunscreen when I was growing up in the 50s
Yeah.
and 60s. And then base your primary care physician's recommendation based on how many risk factors you might have on when you need to start and how often you need to go.
I think that's not a bad idea, as like initial jump off point.
Yeah.
Because
I go every year when I can
Yeah.
get in.
exactly.
But I
And,
haven't. I've had one thing, kind of frozen off, but it wasn't a basal cell. And at my advanced age, the fact that I haven't had a basal cell yet, knock on wood, I'm really happy.
I knocked on wood for you on that one because I see your skin type. It makes me nervous.
And I have 2 moles, but I've always had them, and they have not ever changed. One right here and one on
Yep.
my thigh, and they
Good.
never changed. So, but I
Yeah.
have had major sunburns.
The one caveat, the one thing I'd like to throw out on that is, remember early in the talk I said I see things through the Mohs surgeon perspective. So I see the spots that have, and I hear the stories that everything has turned out to be basically cancer by the time someone's seeing me. So like I hear all the stories, right? And it does happen where someone goes ask their primary care doctor and they're like, oh, it's nothing, and it turns out to be something. So if you do have something that doesn't feel right or look right, and it's just not, you ask your primary care doctor, it's just not sitting right with you. Or if you, even a dermatologist, you go to a dermatologist and they're looking at it, they're saying, oh, it's probably fine, and it's just not sitting right with you, and something's changing, just get it checked out again. You're only getting one slice in time when someone looks at it, and you're only getting kind of their view of it too. So this is one of those places where you kind of have to be your own best advocate.
Yeah.
Well, thank you.
Mm-hmm.
Good. Any other questions? Well, I think this was an absolutely wonderful presentation. Very thorough. I don't know if you saw some of the comments before people left that how much they enjoyed it. So
Yes.
Well, I'm glad people enjoyed it. It's always hard to kind of titrate the information for everybody. But I kind of want to just cover everything broadly and give people a little framework, especially when it comes to treatment. There's one last thing, and I thought about it about 5 times as I was going through the talk, and I kept moving past it without talking about it. And I timing wise, I've kept you guys longer than I ought to. But one important thing, even though Mohs surgeons treat melanoma, early stage melanoma, before it needs a sentinel lymph node biopsy, traditional Mohs surgery, the fast Mohs, is at best controversial in its use for melanoma. And oftentimes, so personally, I treat with melanoma in situ and stage 1A melanoma with something called slow Mohs. So it combines kind of the best of fast Mohs, which is the 100% margin evaluation, with a different preparation of the slides that takes longer, but it helps visualize the melanoma cells better. So fast Mohs is done with frozen sections, and slow Mohs is done with something called permanent sections. And it doesn't matter much for basal and squamous cell, but for melanoma, it makes a huge difference, because melanoma cells, freezing them, it doesn't, it leads to artifact and potentially suboptimal visualization of the melanoma cells. So generally speaking, probably more often than not, Mohs surgeons actually don't use fast Mohs for melanoma. Now, there are some that do, and it's a hotly researched and debated topic. But you know, I can tell you at Hopkins, they don't use Mohs for melanoma, fast Mohs. At Mass General, you know, Sloan Kettering. So that should give you, you know, some idea about, you know, where my feelings and beliefs fit into the whole thing. So, you know, if you do have a melanoma in situ, you do get sent to a Mohs surgeon. It's actually not going to be the fast same day result Mohs that you get for basal and squamous cell.
Mm-hmm.
Very interesting.
Yeah. All right, very good. Well, I'm
Okay.
happy to have talked. Hopefully I helped some people out and, you know, give some good info. And if anybody has any other questions, I'm always happy to help, and go get your skin checks.
Yep. And thank you. And we're going to let you go and go home and go help see those kiddos before they go to bed. So, but thank you
They're the
so
best
much.
before bedtime.
Yes, they are. But thank you so much for this
Hey, anytime. It's
wonderful
been an
presentation.
absolute pleasure. Thanks, guys.
Thank you.
Yep, anytime.